is that the pleural effusion? So I think all of you already got the answer from the handout. So I will just give you the answer. So when there is a back wing sign, which is in the middle video, so you can see that actually there is a fluid collection surrounding the lungs, so that means it will causing the back wing. Well, for those, the other two pictures is actually showing the large pericardial effusion that is developing from anterior and pushing the lungs towards the back. So at the first trimester, sometimes we are receiving some referrals for early onset of the bilateral pleural effusion, but actually they are just pericardial effusion. So whenever you are seeing a pleural effusion, we need to differentiate if it is primary or if it is secondary. So of course there is a long list of the causes for the pleural effusion, and of course we need to look for one by one. But after ruling them out, actually we need to think of the primary cause, which is actually the lymphatic malformation, and it will reduce the survival to around 60%. And of course some intervention may improve the outcome, and I will elaborate it a little bit more later. So before any investigations, if we can get any hints from the ultrasound, so actually some features may suggestive of the primary instead of the secondary pleural effusion. For example, like when one side is more predominantly affected than the other side, or for those, even though when presented as hydropic, but actually the pleural effusion is the most predominant signs than any other hydropic signs. So I think these two are the most important thing. So considering the investigations, of course we want to rule out any secondary causes, but the question is, when should we consider testing for resorpathies? Because I think it is the most challenging question, because it is more costly than other microarray or karyotyping, and sometimes it may take a little bit longer time to get the result. So when should we consider it? Of course, this is very busy slide, but of course, I think many of you already know that if there is additional ultrasound features, you may think of resorpathies a little bit more when CMA negative. But of course, for the isolated pleural effusion, it is much more challenging. Another busy table, but what I would like to draw your attention is, from this paper actually was conducted retrospective data with more than 20 years. Actually, you can see that for those presenting earlier on with isolated pleural effusion without any anomaly, actually no matter if it is unilateral or bilateral, there was no Noonan cases before 24 weeks of gestation. But after 24 weeks of gestation, no matter if it is unilateral or bilateral, actually there are quite a number of them, around 1/5 of them actually presented later on or confirmed later on to be Noonans. So what I would say that if there is a isolated pleural effusion and presented later on, actually you may consider a little bit more on Noonan syndrome or resorpathies. So how about interventions? So I think all of you already know that there could be pleural effusion could lead to some complications like pulmonary hyperplasia, polyhydramnios, cardiac failure, and also hydrops. And actually 60 to 70% of the cases already hydropic at the very first presentation. And here are the list of the poor prognostic indicators, and of course you don't want the baby to be hydropic afterwards. So you can see that if it is non-hydropic, the survival is around 70%, but if it is hydropic, actually it was halved. So that is the time that we need to consider to have the prenatal intervention for those with poor prognostic factor or already hydropics. Here are the types of the prenatal interventions. You can search from the literature. So which one is better? Of course, each of them has some kind of risk or complications that may arise. For example, like the follicocentesis, there is a high chance of reaccumulation of the pleural fluid. And for the shunting, actually there are shunt-specific complications like blockage, disnortment, or migration that you may need to have repeated procedure. Well, for the pleurodesis, actually there is a limited experience and also some safety concern because there was a reported case of maternal death after the pleurodesis. So let's compare the outcomes for the interventions. So here, when we are comparing those with intervention and without intervention, actually, for those with intervention, it seems to improve the survival rate, especially for those with hydrops. Actually, after intervention, actually you can see that the here Okay, so here is the, with hydrops, actually it is markedly improved after the intervention. However, for the prosthesis, when we are getting a little bit more data from the more recent publication, actually you can see that there are conflicting results. Okay, so while for shunting, actually it seems to be best, and here is the more recent data, and you can see that from the most recent decade, and the survival rate was improved from the shunting, no matter for the hydropic one, and also the non-hydropic ones, and up to 100%. So here is the proposed algorithm for the evaluation and also management. Of course, first of all, we need to look for any poor prognostic factor. After that, we need to consider if we should have the investigation first or if we should have the treatment at the same time, if there was a significant polyhydramnios or hydrops or medial sheath. Because we know that if there is significant pre-effusion, actually there is a higher chance of pulmonary hyperplasia, and of course if it developed earlier, actually the prognosis will be worse. And most of the authors also suggest to have the intervention before 34 weeks of gestation, and after 34 weeks, we may consider to have the delivery with or without prior thoracentesis. Okay, so more on the technical stuff. Okay, so the technical challenge of the shunting. So I have no disclosure. And here are the shunting instruments. So first of all is rocket shunt. So it is the most old-fashioned one and the biggest one. And here is the Harrison shunt. You can see that the introducer is thinner. And here is from Japan, double basket shunt, but it is not available in Hong Kong. And here is the Sumatest shunt. You can see that this is the most finest one. So the first challenge is there is limited surgical access window for some cases. So you can compare the size of the introducer diameter. So as after you the rocket shunt, actually is the thickest one, and then Harrison, and then Sumatest. So because I do not have the basket shunt for you to illustrate the size of the introducer, so I can't put it over here. But you can see that whenever there is an anterior placenta, you can see that there is only around 1 to 2 cm of your access window. And then sometimes for a Sumatest shunt, it is much fine. So that's why we can still do the procedure smoothly. So just to prove that it was complete. Okay? So this is the maternal end as well. Okay? So that is an additional advantage. For example, if we are doing at the earlier gestation, actually the fetus is much smaller. So when you are using a more fine introducer, actually it may cause less damage to the fetus as well. Well, for another challenge is the bilateral shunting. So sometimes there is a bilateral fluid effusion and quite significant, and you may need to consider to have the shunting for both sides. So after one side of the insertion of the shunt, actually you may try to roll the baby over and then going over to another side and then do the shunting at the same time with the same entry. And it was reported to have the 60% of the successful rate. But the problem is the rocket shunt is no longer available. I don't know if it is available in other countries, but as far as I know, in the UK and also in Hong Kong, actually they are not available because the manufacturer is no longer producing the shunt. Okay. So what we are using is using the Sumatest introducer because it is fine, and even though if we are doing 2 SS, actually we can minimize the manipulation and also not increasing much risk of the PPROM or other complication. Okay. Third challenge is where should we put the shunt? So what I would suggest is to put it over to the posterolateral side because the baby is always naughty. Whenever there is a toy for them, they will try to remove it. So let me show you this video and show you that the baby is very naughty and then to scratching the shunt, okay, anteriorly, okay, and very tempted to remove it. So actually for the same case and in the next occasion, you can see that the baby successfully pulling out the shunt. And if you take careful of this video, actually there are 2 shunts. So this naughty baby already removed 1 shunt and then another. Okay, especially for the pigtail shunts, actually it is the baby will be more tempted to remove the shunt. So another thing is we need to avoid the nipple. So if we are aiming at anterior side, actually we may theoretically hurt the nipple and that may affect the breast development during the adolescence for the female fetus. So for the level of insertion, I would suggest to have the lower thorax insertion because, of course, the lung is in triangular shape. The chest is also in triangular shape. So the base is actually the most spacious region for us to have the shunt insertion. So we know that where we should target at, but how could we achieve that? So to optimize the fetal position and minimize fetal movement is the goal. So of course, we need to be patient. We may give some pathogen to the mother in order to put the baby into sleep, but actually we may consider to have a more direct method to have the fetal anesthesia. And here is just a sample of how we do the dilution or mixture of the medications according to the estimated fetal weight. And also sometimes depends on the gestation and feasibility, and we may also consider to have the ECV. So another challenge is the if it is very close to the uterine wall. So actually after the shunt insertion, so illustrated in this video, you can see that beforehand, actually the space is quite sufficient from the uterus and also from the fetus. But during the manipulation and after shunt insertion, you can see that the fetus just jump up and also much closer to the uterine wall and leaving us a very, very narrow window, okay, for us to release the maternal end of the shunt. So, if we do nothing or we do not consider this as a problem, what we would result in is this. Okay, we were releasing the shunt to the maternal uterine wall. But luckily this was not done by me, I was not involved in this case. Okay, so you can see that if we are leaving the shunt over the maternal uterine wall, we may need to consider to have the emergency mini laparotomy just showing here to remove the shunt or remove the shunt during the C-section. Okay, so how to minimize the risk? So we must leave or create some space in between the fetus and the uterine wall. So how can we do that? So I think these two pictures, you may have some idea of it. So I'm not doing thoracocentesis, but I'm doing the shunt. So that's why I'm not choosing the shortest distance closest to the uterine wall in order to get away the fluid. Instead, I will leave some space over here in order to have the space for me to release the maternal end and also to do some manipulation. So here you can see that after the insertion of the shunt, even after I have created some angulation over here, actually if I just put it perpendicular here, and actually I cannot leave any space for me to manipulate or to rotate the fetus. But if even though if the fetus is very close and then because of the inclination, actually after insertion of the fetal end of the shunt, you can just rotate the fetus a little bit by pushing down your introducer, and you can still achieve the successful release of the maternal end. And of course, it is easier for earlier gestation. Okay. Another thing is that, of course, this is more useful for the luteal case, but I just want to illustrate to you is that if there is oligohydramnios or even anhydramnios, when you are doing some fetal procedure, actually you may consider to have the amnio infusion. So just showing you the video to let you have some impression on after amnio infusion, actually you are creating the surgical space for yourself. Okay. Our enemies is always uterine contractions. Of course, you may choose to wait for the uterine relaxation, but I am always very impatient, and that's why I will give turbolytics. So for myself, I will give a subcutaneous Freckenil, okay, in order to relax the uterus and to create less contraction over the uterus during the procedure. So the fifth challenge is whenever there is a hydropic baby, okay, the skin layer is much thicker and making you less space for you to relax the to release the maternal end. And here shows you the picture. Okay, of course, when the baby is presenting bilateral pleural effusion, hydropic change, you may need to consider to have the early intervention. And so what I did is to do some measurement of the chest wall from the inner chest to the skin region, because I need to estimate how much I should release over the fetal end and also how much for the maternal end. So of course, ideally, we need to try to avoid the thickness region. So we may try to find the thinness region and do the perpendicular insertion because the distance for the chest wall will be shortest over there. And also during the shunt deployment, so I will also leave adequate, but not too much. Can you see that? The not too much length over the fetal side, and then to have a little bit more margin for us to release the maternal end. Otherwise, it will be left inside the underneath the skin. Okay. So the sixth challenge is the bidirectional flow of the shunt. and there is no valve, and that's why it really depends on the pressure between the thorax and also aortic cavity. And you can see that ideally it will be the shunt will be going out and draining out the fluid. But actually, if the intra-abdominal pressure or intrauterine pressure is much higher, actually it will be going backwards towards the chest. So that's why if there is polyhydramnios, I will do the shunting, and after that I will do the amnio reduction. So here's the summary. So I think I've already gone through all these questions and already give you the tips about the surgical techniques and also the steps. But of course, practice makes perfect. Thank you very much.